Добрый день, глубоко уважаемые коллеги. Эта сессия, к сожалению, завершает уникальную программу инновационного медицинского форума. Онлайн-формат позволил нам расширить аудиторию и посмотреть все доклады и обсуждения не только в прямом эфире, но и в записи. И в течение этих 3 дней мы с вами имели совершенно уникальную возможность принять участие в обсуждении действительно инноваций, самых новых проблем, которые обсуждаются и внедряются, их решения в реальную практику. Мы обсудили их в разных областях медицины, и эта сессия завершает нашу программу и будет посвящена актуальным вопросам кардиологии. У нас действительно блестящий спикерский состав. И первое слово я бы хотела предоставить профессору Джузеппе Фаджиону, заведующему отделением сердечно-сосудистой хирургии Веронского университета, который осветит отдаленные результаты после проведения операции по изолированной пластике аортального клапана.
Good morning. I am Professor Fazan from Italy, Verona. I want to thank you very much, Professor Sciacto, for inviting me to this very nice symposium. Unfortunately, due to the COVID, we cannot be there in the beautiful St. Petersburg. I try to do my presentation. I think I will do my best in using these tools. What I'm going to talk to you today is the long-term result of isolated aortic valve repair. Well, as background, valve repair is intrinsically more exposed to relapse, redo, while aortic valve replacement to foreign body related morbidity. Evidence of feasibility of valve repair with satisfactory and reproducible late outcomes were firstly exposed by Professor El-Khoury and Schaffer, yet are far from mitral repair standards. Controversial technique issue relating to extent of leaflet repair, augmentation, calcification, and role of circumferential annuloplasty. Trend toward concomitant root replacement to stabilize repair in bicuspid aortic valve and tricuspid aortic valve, lowering threshold for SV replacement has been described by the Kochev in European Journal of Cardiothoracic Surgery. Role of patient selection to optimize late outcome is also important. The aim of this study was to define late outcome of isolated without root pathology aortic valve repair in all comers, compare valve-related morbidity with concurrent patient cohort having aortic valve replacement, identify variables predictive of adverse event, qualify clinical outcome of patient after valve repair. The methods. We have actually the cases done between 2002 and 2013, so 12 years, of all consecutive patients with pure aortic insufficiency, were 429. Selection for valve repair was no random and was surgeon driven. The exclusion criteria were mixed lesion, aortic stenosis with aortic insufficiency, aortic root pathology requiring concomitant surgical management, aortic root index, prospective control study, repair versus replacement. Endpoints were hospital late survival, freedom from major adverse cardiac and cerebral vascular event, MACCE, freedom from AVR, and functional status. The statistical analysis was a descriptive, was Kaplan-Meier, univariate and multivariate analysis by Cox regression. Propensity matching also applied. Variables, age at surgery, body surface area, gender, congenital lesion, prior cardiac surgery, replacement device, mechanical valve, vessel bioprosthetic valve, or autograft or homograph, associated procedure, length of follow-up. The evolution of repair technique was very well described in one paper from our center, and the preservation or conversion of unicuspid aortic valve, quadricuspid aortic valve into bicuspid aortic morphology. Use of limited fresh autologous pericardial leaflet extension, leaflet plication, central rather than commissural, calcific excision of the raphe versus AVR when calcification, fibrotic raphe excision when retraction, the pseudoprolapse of contralateral leaflet, fenestration, perforation patch repair, AVR when fenestration, subcommissural annuloplasty, circumferential, active endocarditis, and aortic valve replacement. The demography of the patient are described in this slide. As you can see, there is not actually too much of difference between female gender and male gender. Mean age was not statistically significant. Congenital etiology of valve were not statistically significant, and also valve morphology. The only difference was found in the aortic dilatation, the ascending aortic dilatation, were more in the repair group than in the replacement group. The mean follow-up was longer for the replacement group than for the repair group, but roughly around 10 years for the repair group. The operative data are described in this slide. You can see the ascending aortic require replacement in 60% of the repair patient and in 20% of the replacement patient. And you can see the different kind of repair technique in the repair group: annuloplasty, free marginal leaflet plication, rougher leaflet resection, patch repair, shaving, and decalcification of leaflet. And as you can see, among the prosthesis implanted, bioprosthesis was among the most used valve, mechanical, autograft, and homograph. Result: no hospital mortality where we had. We have 33 cases, 7.7% of late death. At follow-up range from 11.8 years to with a range of 7 to 18 years. Similar late mortality, 6 in 109 versus 27 in 320 patients, were not statistically significant. Greater mortality, cardiac mortality, was observed in aortic valve replacement. The overall survival of patient by Cox analysis is similar in the repair group and the replacement group at 8 years, as you can see in this slide. And also the freedom for adverse cardiac events was similar in the repair or replacement, even in this case at 8 years, with a p-value of 0.7. Freedom from reoperation was slightly more in the replacement group than in repair group, but they are not reaching statistical significance also at 8 years. Due to a different baseline demography and a retrospective non-random study design, a propensity matching was applied. The variable we chose was gender, age, etiology of aortic insufficiency versus bicuspid aortic valve versus non-bicuspid, ascending aortic procedure. Based on the above variable, 48 comparable pairs were identified. The demography after matching, where we see in this slide, you can see here, there are no, for different matched patients, no different statistically significant difference in female gender, mean age, congenital etiology, valve morphology, bicuspid versus tricuspid versus quadricuspid were none in both groups, and the ascending aortic dilatation were matching for the same number. Even after the propensity matching, the freedom from major adverse events were similar in repair and replacement group after 48 pairs measured up to the second decimal. And the functional status was class New York Heart Association class 1 with no difference in both group, but obviously chronic anticoagulation, mainly required by a mechanical prosthesis, were mostly in the AVR group. The limitation is obviously evident that this is a non-random assignment to valve repair group. Heterogeneous repair activity among 5 senior surgeons, the evolution of technique and selection during study, including the choice of replacement device, stent test, xenograph, pulmonary autograft, can make a difference. Exclusion of valve-sparing root procedure possibly reproduce worst late result scenario for repair. Propensity matching may partly correct for bias. Conclusion. Comparable survival, though cardiac mortality more common after aortic valve replacement, age, prosthetic valve morbidity. Comparable freedom from redo, unexpected after AVR, stentless valve, Ross operation. Repair rational in younger patients with congenital valve disease, avoid in endocarditis or in restricted leaflet physiology type 3. Implementing valve repair for isolated severe aortic insufficiency may spare up to 1/4 of aortic valve in all comers, provided adequate training and strict candidate selection. The inferences. Inclusion of aortic insufficiency patients with concomitant root pathologies, select individuals with no to mild aortic insufficiency in whom valve-sparing root replacement afford durable outcome. When isolated valve repair is performed preoperative, aortic insufficiency must be at least moderate 3+, when not too severe 4+. Clinical serious intading root procedure may lead to overestimation of isolated aortic valve repair durability. Lowering threshold for root replacement during valve repair advocate a Brussels group, a Curie group, very controversial. Focused assessment of aortic valve repair safety and reproducibility must exclude full root pathology procedure. Thank you very much.
Глубоко уважаемые коллеги, мы благодарим профессора Джузеппе Фаджиана за представление отдаленных результатов собственного опыта и за анализ различных вмешательств при аортальной недостаточности, определение групп пациентов, которые пригодны для изолированной пластики аортального клапана. И важным также является применение в данном исследовании, в данном анализе собственных результатов методов псевдорандомизации, которые позволяют уточнить полученные результаты. Я с удовольствием представляю нашего следующего спикера. Это Роберто Феррари, профессор кардиологии в университете Феррари в Италии. Это экс-президент Европейского кардиологического общества. И Роберто Феррари представит результаты рандомизированного исследования по применению триметазидина у пациентов с стенокардией или острым коронарным синдромом без подъема сегмента СТ, которым в течение месяца до этого выполнялся черезкожное коронарное вмешательство до рандомизации. И это исследование было представлено на горячей линии Европейского конгресса кардиологов, который также проходил онлайн, и было одновременно опубликовано в журнале Lancet. И мы с удовольствием послушаем результаты этого исследования в представлении Роберто Феррари.
Good morning or good afternoon to all of you. I am Roberto Ferrari. I'm addressing this talk with a lot of sadness from Ferrara and not from St. Petersburg, where I was really looking forward to come. But the present situation in Italy, and I think also in Russia, does not allow us to travel. So we fought together with Professor Zlaklo to address the issue of ATPCI, which is an important study to which Russia has participated and actually was our best country. The idea of the study was born in the fall of 2012 when EMA, which is the European Institute for Drugs Approval, confirmed the positive risk-benefit of trimetazidine as an add-on anti-anginal therapy. However, EMA requested further evidence of safety and of efficacy, and particularly the concern was related to safety because, as you know, trimetazidine might or was thought at that time to be able to cause some Parkinson-related disease. And at that time, when we are talking about 2012, the prevalence of angina after PCI was rather high. And you can see that already in 2001, there were studies published in the New England Journal of Medicine saying that about 50% of the patients after a PCI at the first year, they're still complaining of angina. And the same was true from other later studies like Barry, Capri, Reed, and so on, all suggesting that after PCI there is a recurrence of angina in the region of 30%. And I'm sorry, I'm making a mistake. And then later, the Courage trial confirmed this data that after 1 year, 30% of the patients still complain of angina. And this study of Marzilli, who did a positive stress test, he found that after PCI, almost 50% still of the patients has a positive stress test. So the idea was to start APCI, and the primary objective of the study was to assess the efficacy and the safety of trimetazidine added to standard guideline recommended medical therapy, either preventative or anti-angina, and to do that in patients who had a recent successful PCI for stable angina or non-ST elevated myocardial infarction. So the ATPCI really look at patients who had a successful PCI. The background was that the PCI might alleviate symptoms in patients with chronic coronary syndromes who do not respond to optimized medical therapy. And also, and this was still uncertain, it might improve the prognosis in those with an acute coronary syndromes. As I showed to you, previous studies show that angina pectoris might reoccur despite successful PCI. And actually, there is also a paucity of contemporary data on the prognostic benefit of anti-anginal drugs in post-PCI patients. And therefore, we decided to test trimetazidine. Now, you might ask why trimetazidine. Apart from the request from EMA, there were very good reasons to test trimetazidine because, as you know, it is an anti-anginal agent different from the most commonly used either first or second line anti-anginal drug because it does not have any hemodynamic effect. And actually, trimetazidine improves the metabolism of the ischemic myocardium because it favors glucose to free fatty acid oxidation, and in so doing, it allows more anaerobic ATP formation and prevents acidosis. So we thought that ATPCI was really testing a completely new hypothesis. The hypothesis that amelioration of cardiac metabolism in post-PCI patients may be beneficial for the patients. The study plan was as simple as possible, a classical, multicentric, randomized, placebo-controlled study looking at adult patients with stable angina or with non-ST elevated myocardial infarction who have undergone recent successful either elective or urgent PCI. All patients were required to have angina prior to the index PCI and to receive guidelines recommended medical therapy. Patients with severe heart failure, valvular disease, arrhythmias, renal failure, or an acute STEMI, ST elevation STEMI, were excluded from the study. We made all the calculations, and we find out that we needed 5,800 patients in considering an average follow-up of 36 months. But actually, as you will see, the follow-up was needed to be prolonged by at least 12 months in order to have the enough events, which were calculated to be 1,363. The study design, again, was as simple as possible. Within 13 days from the index PCI, patients were included into the study, and they received either trimetazidine at the dosage of 35 milligrams twice a day or matching placebo. Then the patients were followed after 1, 3, and 6 and 12 months in the first year, and then every 6 months until the end of the study. The primary composite endpoint was cardiac death, hospitalization for cardiac events, recurrent or persistent angina, leading to adding, switching, or increasing the dose of anti-anginal therapy or to a coronary angio. We randomized 6,059 patients. However, 52 patients were excluded from the main analysis because of a potential unblinding at the very beginning of the follow-up. So we ended up with almost 3,000 patients who received trimetazidine and 3,009 patients who received placebo. And we had only 2 lost of follow-up. So we analyzed almost all these patients. These patients were coming from 365 sites located in 27 countries. Majority of the countries were within Europe, but there were also some countries in South America, Algeria in Africa, and some countries in Asia. These are the baseline characteristic of ATPCI. And the first point is that there was absolutely a matching between the treated and the placebo group. And as you can see, the patients were rather young. The mean age was 61 years. Majority of them were male and Caucasians. Majority of the patients had at least a class 2 and many also class 3 to 4 angina. And as you can see, there were more patients in the elective group with respect to the urgent group. Majority of the patients had, actually 55% of them, had a single vessel disease, 30% double vessel disease, and only 13% triple vessel disease. Majority of the patients had the normal ejection fraction, and only 2.5% of them had an ejection fraction below 40%. In terms of previous medical history, as you would expect, there were several patients, 82% with hypertension. There were 48% patients who had a previous myocardial infarction, and in 34% they were submitted to revascularization. Many patients had diabetes, some peripheral artery disease, some stroke. And here you have the treatment of these patients. Again, a perfect matching between the two groups. And what I have to say, these patients were extremely well treated, because almost all of them was receiving double platelets agents, mainly in terms of aspirin and clopidogrel, but some also had ticagrelol. Majority of patients were also receiving lipid-lowering agents in 96%, and usually these were statins, and only few of them had other lipid-lowering agents. Almost all patients received angiotensin-converting enzyme inhibitors, either in the forms of angiotensin receptor blockers or of angiotensin-converting inhibitors. And some of the patients were also receiving anti-aldosterone drugs, and this probably because they were hypertensive, because very few of them had an ejection fraction below 40%. And in terms of anti-anginal therapy, they were again all very well treated, because 83% of them was receiving beta blockers, 27% calcium blockers, and long-acting nitrates was present in 12%, and other anti-anginal therapy in 20% of the cases. And this is the primary endpoint of the ATPCI study. And this slide has two very important messages to you. The first message is that these patients are doing extremely well. I should repeat to you that these are patients with a successful PCI and optimal medical therapy. And you can see that over 5 years, the primary endpoints occurred only in 25% of them. That is the reason why we had to increase the follow-up. And the second message, which is less good, is that trimetazidine, when added to placebo, did not modify the primary endpoint. And this was true either for the elective patients or the urgent PCI. Although for the elective patients, there was some numerically better better effect of trimetazidine, but this did not reach statistical significance. And even when we are looking at each component of the primary endpoint, the results are always the same. It doesn't matter, it doesn't matter if patients were having elective or urgent PCI in terms of cardiac death. It was always not statistically significant. It doesn't matter for the hospitalization, whether they have elective or urgent PCI, for the recurrence of angina leading to coronary angio or recurrence of angina leading to a therapeutic change. And also, we did not find any other differences according to the pre-specified subgroups. It doesn't matter if the patients are age more than 70 years or less, where they are female or male, where they had moderate kidney insufficiency, whether they had history of diabetes, history of myocardial infarction, history of coronary vascularization, or they had single or multivessel disease. Always there was no real statistically significant changes, and interval were quite big. Then the investigators also took a look of the reported angina attack during the study. And again, this slide is showing to us two very important messages. The first message is that over time, contrary to what was the premise of the ATPCI study, angina does not return, but actually tend to disappear. And this is a very good news. Only 15% of the patients had angina after 1 year, and 9% after 4 years or at the end of the study. The other message is that trimetazidine or changing of metabolism in this particular set of patients does not improve the occurrence of angina through the time. In terms of a serious adverse event, as you can see, again, there was a perfect matching between the two groups, and there were not an exceeding of adverse event in the trimetazidine group, and this is a particularly important and relevant for the nervous system disorders. Actually, there were slightly more events in the trimetazidine, but this did not reach the statistical significance. So in conclusions, the event rate in the population of the ATPCI study was lower than expected, requiring an extension of the follow-up to 5 years. The prophylactic use of trimetazidine, when added to the recommended medical therapy, did not improve the outcome of the ATPCI population after a successful either elective or urgent PCI. And no trimetazidine-related safety issue were identified in this population. And I would like to add some take-home messages, because patients with chronic coronary syndromes receiving a proper optimized medical therapy combined with successful PCI have a very low events rate and very low recurrence of angina. Honestly, the events rate in this particular population is similar to the population without any cardiovascular disease. And this is a very good news. The improvement of cardiac metabolism with the trimetazidine does not improve outcome or recurrence of angina in this particular population, and most likely is not even necessary because these patients are already doing very well. So the take-home message is that the patients with chronic coronary syndrome disease should, in my opinion, have a very rigid control of their risk factors. They have to take the available preventative and anti-anginal drugs, which, thanks God, are available almost to everybody because they are rather cheap. And if the symptoms persist, angioplasty is, in my opinion, indicated. But of course, needs to be a successful angioplasty, as it was in the ATPCI study. Finally, let me acknowledge the 6,200 patients from the 365 centers from the 27 countries, which and the 2,190 investigators that made the ATPCI study available. Let's thank all the members of the study committee, which are listed here in this slide for the data monitoring, the data management, the endpoint adjudication, the safety adjudication committee, and finally, my great acknowledgement to Servier, who supported the study and who made this data available for all of us. Actually, if you are interested to learn more about the ATPCI study, the first publication is already available in the Lancet, in the special hotline issue, and very soon will be available also in the paper version of the Lancet, but this is just the beginning. We are digging into the database of the ATPCI in order to produce many more other studies. So I take this opportunity to thank all of you for listening at me, and my really deepest regret not to be in person in St. Petersburg and not to be able to shake hands with all of you. Thank you very much indeed. Thank you.
Мы благодарим профессора Феррари за блестящее представление результатов этого исследования. И действительно, как часто эффективность терапевтических стратегий, которые мы предлагаем на основании патофизиологических подходов, не подтверждается в рандомизированных клинических исследованиях. И это, собственно, еще один такой пример отлично выполненного рандомизированного исследования с охватом более 6 тысяч пациентов в 27 странах мира, когда предположение о возможных эффектах триметазидина, препарата без гемодинамических эффектов, но потенциально влияющего на метаболизм ишемизированного миокарда, не привело по сравнению с плацебо к улучшению исходов у пациентов с успешно выполненным черезкожным коронарным вмешательством, не повлияло на частоту или характеристики стенокардии. И профессор Феррари подчеркнул, что у таких пациентов достаточно низкая частота событий, и, может быть, это сыграло свою роль в полученных результатах, но по результатам этого исследования нет необходимости в этой клинической ситуации использовать триметазидин, а главным подходом остается контроль факторов риска и назначение доказанной терапии при хроническом коронарном синдроме. Глубоко уважаемые коллеги, профессор Массарт не сможет принять участие в нашем симпозиуме, но я с огромным удовольствием приглашаю к выступлению профессора из университета в Осло в Норвегии Ярле Вааге, с коллективом которого Центр Алмазова связывает давнее эффективное научное сотрудничество, и профессор Ярле Вааги является крупнейшим специалистом в области молекулярной биологии в кардиохирургии. Зоной его интереса являются также фундаментальные аспекты миокардиальной защиты и церебральной протекции. Его доклад посвящен митохондриям, вызывающим воспаление при перфузии, хирургических вмешательствах, травмах и критических состояниях.
Våge from Oslo, Norway. I have to say that it's a great pleasure to have the opportunity, and it's an honor to speak at this anniversary symposium or conference at the Almasov Institute. I have had contact with the Almasov Institute for almost almost 20 years, and I have been impressed by the progress that the Institute has done. And I must congratulate the Institute with its 40th anniversary, and in particular the director, Professor Schlachto, who has been, I think, a very visionary and hardworking leader of the Institute. I will speak about mitochondria causing inflammation during illness, like reperfusion injury, surgery, trauma, and critical illness. This is a sterile inflammation, and it activates the innate immune system. It's activated when pathogen-associated molecular patterns, also called PAMPs, or non-pathologic sterile damage-associated molecular patterns, DAMPs, bind to and activate specific so-called pattern recognition receptors on immune cells. The most studied and maybe the most important immune receptors are the toll-like receptors and formyl peptide receptors. Among the immune cells are leukocytes, mast cells, and killer T cells. Also, several non-immune cells, cardiomyocytes, for instance, and endothelial cells have immune receptors and can be turned into inflammatory cells. In addition to the innate immune system belongs the complement system, cytokines, chemokines, and more. This picture shows you the innate immune system, which is the rapid response system to an intruder, and the adaptive immunity, which is a slow response. In the innate immunity, you see all the different cells that belong to it. You see the complements, and you see that there is a small overlap between the two systems by the natural killer T cells. So what about the mitochondria in the innate immune system? This talk is an overview, hopefully to inspire, because you will actually see there are a lot of open research areas here. In the literature, there are many reviews and much less original research. Mitochondria are more than the powerhouse. They cause inflammation. But this talk will not go into the depths. It is a little more like surfing on the tops. The whole field with mitochondrial damps is quite new, basically mainly from 2010, and there are much more to investigate, including the mechanisms. And interesting, there are no drugs that directly can counteract the mitochondrial damps, which would be very important because they are very important in the whole body inflammation caused in critical illness, trauma, surgery, etc. But a lot of research is ongoing to find drugs. Blocking receptors may not be sufficient because there are many signaling ways, so blocking just one of them may not be sufficient. So what about the mitochondria and the innate system? This starts with bacteria. And evolution made the eukaryotic cells to engulf bacteria. So they ended up inside the cells. This happened approximately 2,000 million years ago. And these became the mitochondria. And in certain trauma, the mitochondria are injured and release their damps. And for instance, as I will come back to, it's mitochondrial DNA and also formyl peptides plus more. You see they have the same in bacteria. For instance, in sepsis, they also release formyl peptides and bacterial DNA. And they act on cells, neutrophil cells. The toll-like receptor 9 is probably very important, and we have the formyl peptide receptor 1, and they stimulate leukocytes to do all the bad things they do in such situations. This is just an example of acute lung injury. So, what are the mitochondrial dumps? Well, ATP is a mitochondrial dump. It causes inflammation, activation, apoptosis, and induce release of reactive oxygen species. I will come back to all these later, but we have succinate. This I will not mention anything about. But we have cardiolipin, which belongs to the inner mitochondrial membrane, and when there is an injury of the mitochondria or stimulation, they are translocated to the outer mitochondrial membrane. We have the N-formyl peptides, the mitochondrial DNA, which is the mitochondrial damps that has been most studied, and we have the mitochondrial transcription and factor A. And all these I will come back to. When we have a necrosis, the mitochondria injure as well, and they release all these, acting on receptors, which again acts on different immune cells, macrophages, neutrophils, dendritic cells, etc. So you see, this is a very complicated game. I'll just first mention something about the endothelium, because the endothelium is in all the blood vessels and the microcirculation, so it's a huge organ. And when that is injured, there are a lot of bioactive substances as released. There are more than 1,000 bioactive substances inside the endothelial cells. And there's an increase in permeability and caused by different mechanisms. And increased permeability causes edema. And edema is a key part of the whole body inflammation. Here is an example how the N-formyl peptides from the mitochondria cause endothelial injury. They bind to the formyl peptide receptor 1, and they make the endothelial cells contract. So the pores in the endothelium increases, and they causes a possibility for leukocytes to extravasate. And this means increased endothelial permeability. At the same time, this stimulation of endothelial cells causes cytoskeleton rearrangement, cytokine production, and there is a release of TNF-alpha, interleukins, etc. And the end result is an inflammation in the endothelial environment and increased permeability. What about the N-formal peptides in ischemia reperfusion? These are real culprits. They cause a lot of changes in leukocyte function, causing tissue damage, chemotaxis, phagocytosis, release of reactive oxygen species, release of leukocyte granula with all their content and lysosomal enzymes, etc., etc. They participate in chemotaxis by platelets. As a total, their role is unclear in ischemia reperfusion injury, but they are likely to play a part, maybe an important part. But there's a lot more to study here. However, receptor blockers are cardioprotective. It has never been studied how much N-formal peptides are released in a myocardial infarction, but it's likely to be released a lot. This is a study in isolated rings of mesenteric artery, and you study the tension. The vessels are contracted and then are added different concentrations of N-formal peptides, and you see it delays. And when a blocker, which is actually cyclosporin, a blocker of formal peptide 1 receptor is given, then this relaxation is inhibited. This is an important observation because mitochondrial N-formal peptides induce a cardiovascular collapse and sepsis-like syndrome. Infusion of these peptides in rats caused hypothermia, blood clotting, and increased vascular permeability and shock. And when studied hemorrhagic shock in rats, increased blood levels of N-formal peptides were found. Now we go to another DAMP, the cardiolipin. Cardiolipin is, well, as the name says, lipids are located in the inner mitochondrial membrane. And the name cardiolipin is because first it was discovered to be in the heart. But cardiolipin has a procoagulant activity. This has been found in traumatic brain injury. There is very little done with cardiolipin in shock and most kinds of trauma and in ischemia reperfusion. But this is a study in patients with cardiac arrest and study the outcome of cardiac arrest. And then cardiolipins were measured and associated with the outcome. On the top panel here, you see good outcome of black columns, poor outcome of red columns, and are different cardiolipins. All these you see here are different cardiolipins. And you see for all of them, their level are higher in patients with poor outcome. But the only one that was significant was the 75. The investigators then did a cardiolipin score, and which you see here, and that is actually the accumulated score of all cardiolipids except the one that was significant. And this cardiolipin score is in red here, and the cardiolipin 75 is in blue. And you see here it's increasing. PCAC score, this study is from Pittsburgh, and the P here stands for Pittsburgh. It is a score for outcome that was created at the university in Pittsburgh, so it's their own. But what it says is that the worst outcome, which is 4, had the highest cardiolipin score and the highest level of cardiolipin 75. And then they measure this in the plasma, and you see the same thing. Cardiolipin is much higher in patients with poor outcome. Then we have another, the mitochondrial transcription factor A. This is a member of the HMG box family. It interacts with mitochondrial DNA and regulates its transcription and replication. It is also a strong inducer of inflammation. It increases cytokine production. And it's an interesting thing. It lives in some kind of symbiosis with the mitochondrial DNA. It's bound to mitochondrial DNA. It interacts with the membrane reception RAGE, and that assists to internalization of mitochondrial DNA. So when this complex with TFAM and mitochondrial DNA comes to another cell, they are both extracellular, and they come to another cell, then the TFAM assists mitochondrial DNA to get into the cell and cause damage there. It is also shown, TFAM is shown to be pro-inflammatory in hemorrhagic shock. Like cardiolipin, there's very little information of TFAM. So I can only inspire people to do research on this. If you look at it for ischemia, reperfusion, and critical illness, etc., there's so little. But this is in hemorrhagic shock in rats, and you see how the TFAM level in blood increases 4 hours after there has been hemorrhagic shock, resuscitation. 4 hours after the end of resuscitation, it's much higher. And here we have cell cultures study. This is normal medium, then the vehicle, and then different concentrations of TFAM. And you see that this will increase TNF alpha, and both in peritoneal macrophages and in a cell line. So it stimulates production of TNF alpha. In the same way, if you infuse TFAM into rats, you get an increase in interleukin 6 and in TNF alpha in the blood. This is a substantial increase. It's like 100-fold. Then we come to another player, ATP, which is supposed to be the energy in the body, but it has a completely different effect when it's released and become extracellular. It's a key player in extracellular signaling, and it's released by cell damage, exocytosis, and the specific ATP release channels. It triggers vasodilatation, platelet aggregation, chemotaxis, cytokine release, and increased adhesion of leukocytes to endothelium. In other words, all these aspects of inflammation. Mitochondrial DNA is the one that has been most studied. The interesting thing is that mitochondrial DNA follows the female. So the mitochondrial DNA in a child comes from the mother. So this is just an example of that. The father offers, here, take some of my DNA, and the mother mitochondrial says, no, thank you, I have got my own. You should be a strong and independent mitochondrion. If we look at the structure, this is normal DNA, the spiral. But mitochondrial DNA has this ring form and is much, much smaller. And you see, bacterial DNA has the same. This is a study from our own group published in 2012. We see that 3 hours after myocardial infarction, we have a substantial increase in mitochondrial DNA. And this is reduced after 24 hours. But if you look at the scale, the increase is still substantial. And there's a tendency it keeps above normal. These are patients, the control are patients with stable angina pectoris. And actually, this difference is much bigger than it looks here because of the scale, which is very coarse. This is just the same. The mitochondrial DNA are measured by PCR with 2 different genes. So they show basically the same. Here we see the level of mitochondrial DNA in transmural myocardial infarction. It's 3 hours after reperfusion, and non-transmural. This is a study in isolated perfused mouse hearts. And we look at mitochondrial DNA release. It's before ischemia and infarct of the mouse heart, and after you see how it increases. This is another study done by a Chinese group that was published 3 years later. And basically they found more or less the same, except they had a somewhat different scale, and they find a very high level on day 1 and also increased on day 3. And these are healthy volunteers, and this non-mitochondrial infarction controls, I'm not quite sure what they are because it was not clearly stated in that article. But the picture is mitochondrial DNA is released after myocardial infarction. In another study from our lab, published in 2016, extracellular mitochondrial DNA activates NF-kappa B using the toll-like receptor 9 and induces cell death in cardiomyocytes. These cardiomyocytes were in culture primary cardiomyocytes from mouse hearts. It's a pleasure to present this study here. release of mitochondrial and nuclear DNA during on-pump heart surgery, kinetics and relation to extracellular vesicles. This is a collaborative study between our group and St. Petersburg, the Almasov. Actually, most of the work was actually done in the Almasov. So what does this show? This is mitochondrial DNA measured preoperatively. Remember, this is a logarithmic scale. So the patient is operated and prepared for cardiopulmonary bypass, and you see that the surgery itself causes, and these changes are fundamental with this logarithmic scale. Then, when cardiopulmonary bypass starts, the increase is even larger, and this is maintained during the operation. This is 5 and 30 minutes of reperfusion. This means that the ischemic heart has started to be reperfused, and it's all maintained at a high level. However, only after 1 hour postoperatively, it is back to normal, which is reasonable because the half-life of mitochondrial DNA is only a few minutes in the circulation. So it means that when this is at this level is maintained for during most of the operation, it means that there is a continuous release. Actually, we see the same pattern for the nuclear DNA. We also measured the mitochondrial DNA in the coronary sinus and in the pulmonary artery to study if there was a special release or maybe disappearance over different vascular beds. To make it short, there was no particular release, or neither in the coronary circulation or in the pulmonary circulation, and neither did any mitochondrial DNA being inactivated or disappeared. So the release was into the main circulation caused by surgery itself and the effect of the cardiopulmonary bypass with foreign surfaces activating blood cells. This is a further study of this. This was done in St. Petersburg by Anton Fedorov, studying in the extracellular vesicles. You know, these small microvessels, these small microvesicles that are being released. And we see mitochondrial DNA in the supernatant preoperatively. At the end of operation, it is increased. Then in the microvesicles, it is high all the time. And in the small microvesicles, these are the exosomes, which are less than 100 nanometers, is also high. But if we look at the distribution and within the blood, we see, and the blue here is on the microvesicles, which are above 100 nanometers in diameter. Before surgery, at this stage, most of mitochondrial DNA will be in the microvesicles. However, after or the end of surgery, there's a lot more being free, and also there's a bigger increase in the exosomes. We have difference between the different fractions also for the nuclear DNA, and the pattern is somewhat different from the mitochondrial DNA. It must be mentioned that nuclear DNA is also inflammatory and causes inflammation, but much, much, much weaker than the mitochondrial DNA. So what about mitochondrial DNA in shock, trauma, and sepsis? It is most studied on the mitochondrial dumps. It's shown to be increased in blood in all these situations. We know it has a lot of inflammatory effects, and we believe it is important. But since it's not possible actually to block it, we really don't know how important it is. And there are so many things that causes the whole body inflammation in these situations that maybe to eliminate only one factor is insufficient to importantly modulate the cause and the whole body inflammation. And even if it's the most study of the mitochondrial dumps, it is not that much studied. It is a measure that is increased in the blood in some situation, but that's it. And actually, there are more reviews written than original research. A lot of reviews suggesting that they're very important. And once again, there's no way to block it. So, thank you very much for your attention. And this is now finished. Thank you.
Профессор Ваага, большое спасибо за теплые слова в адрес Центра Алмазова и огромное спасибо за столь блестящее представление самых современных данных о роли митохондрии, ассоциированного с ними воспаления в патогенезе различных патологических процессов. И, конечно, пока нет средств на это влияющих, но это, безусловно, основание для поиска новых терапевтических подходов. Глубоко уважаемые коллеги, наш симпозиум, на котором мы с вами познакомились с результатами фундаментальных исследований, когортного, рандомизированного клинического исследования, является замечательной иллюстрацией того, как зарождаются и внедряются инновации от эксперимента к реальной клинической практике. Чем бы мы с вами ни занимались, какие бы исследования ни выполняли, кем бы мы ни были, врачами, исследователями, преподавателями, мы все наши усилия направлены на улучшение качества жизни, увеличение продолжительности жизни наших пациентов. И я желаю всем нам успеха в этом деле. Я благодарю спикеров. У нас очень много благодарностей в чате при просмотре YouTube. Я благодарю аудиторию за проявленное внимание и интерес. И до встречи на следующем инновационном форуме в Центре Алмазова в городе Санкт-Петербурге. Всего доброго!